This is the videotaped deposition of Dr. Chambliss Harrod. This deposition is being held at 7301 Hennessy Boulevard in Baton Rouge, Louisiana on October 21st, 2019, at the time indicated on the video screen, which is 8:01. This time, would counsel please introduce himself to the record?
Peter Ellis on behalf of the plaintiff, Mickey Singleton.
And my name's Sid Hardy. I'm here on behalf of Walmart.
Please raise your right hand. Do you swear that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth?
Yes.
Dr. Harrod, again, my name is Peter Ellis, and I represent Ms. Singleton in this lawsuit. If you would, please introduce yourself to the jury by giving your name and professional address.
Sure. It's Christopher Chambliss Harrod, 7301 Hennessy Boulevard, Baton Rouge, Louisiana, 70808.
And we're here tonight at Bone and Joint Clinic just down the street from Our Lady of the Lake. That's where your practice is located?
Yes.
Okay. If you could, please describe your educational background for the jury, please.
Sure. I finished med school at LSU New Orleans in 2006, and then Harvard Orthopedics in 2011 in Boston, and then finished Thomas Jefferson University, Rothman Institute, Combined Orthopedic Neurosurgery Spine Fellowship in 2012. And then I've been employed at Bone and Joint since August of 2012. And I'm board certified in orthopedic surgery since September of 2014. And I do about 99% spine as far as my subspecialty of choice.
So, doctor, you studied spine surgery. You did your residency on spine surgery. Do you continue to follow the literature on spine surgery?
I do.
Okay. And again, you're board certified in spine surgery.
I'm board certified in orthopedic surgery. There's not really specifics per se for spine.
Well, I'd like to, at this time, tender you as an expert in orthopedic spine surgery.
We will stipulate to the doctor's expertise.
Thank you. Dr. Harrod, how did it come to pass that you started treating Miss Mickey Singleton?
I'm sorry, I've got all these different notes, and some of them are my partner's notes, but I think I'd seen Miss Singleton beginning, I want to say back in 2015, January 7th, 2015.
Okay. And now are you aware how she found your clinic, how she found you?
Sure, I believe she was referred by Dr. I think Dr. Barrett Johnston or Dr. Rathbone, her primary care doctor, had sent her to me.
Okay. Dr. Harrod, and I assume you've treated Miss Singleton since that time?
I have, yes.
During that treatment over the past several years, do you recall an incident at Walmart around October 2016 involving falling boxes?
She did come in and she had seen me on 12/5/2016, I guess about, a month and a half, 2 months or so after this accident. And she said that since that time she'd had worsening problems with her neck and somewhat going into the shoulder region or arm.
What did she tell you happened to her during the Walmart incident?
She said that I believe that a box had fallen onto her head.
You mentioned that she described an increase in neck pain.
She did.
Did you end up treating her to address that increase in neck pain?
I did.
And how so?
Ultimately, I ended up treating her with a revision surgery. She had, as I had previously noted, an ACDF done from C4 to C6 in the past that I had performed, and she ended up getting a CT myelogram of her neck, and specifically just talking about the neck. She continued to have symptoms. We got a myelogram of her neck, and one of her grafts at C5, C6 looked like it was either fractured versus a pseudoarthrosis at that level. It looked like it was a solid fusion at the upper level, and at that point she continued to have troubles, and we offered her revision surgery to fix that.
Okay. And doctor, you mentioned the ACDF. Is that a spine fusion?
It is. It's anterior cervical decompression and fusion.
Okay. And that would be to address her neck pain?
Correct. She'd already had the C4 to 6 ACDF done in the past before this accident in question. And then given that she had come back with increasing issues, that's what prompted us to get the myelogram, and then ultimately ended up treating her with a revision surgery, both from the front and from the back.
And doctor, before we get too far, the jury will be asked to decide in this case whether the boxes that fell on Miss Singleton at Walmart caused the need for that second revision neck surgery you mentioned. Do you believe, more probable than not, that the boxes that fell on Miss Singleton caused her increase in neck pain and the need for that second surgery?
I do.
And the treatment to her neck that has continued to follow as a result of that incident?
I do.
Okay. If you would please describe to the jury the first neck surgery, sort of what that entails, what you were addressing.
You're talking about the one before her, before her accident?
Yes, doctor.
Okay, sure. So as I noted before, I had seen her back beginning in January of 2015, and looking back at my notes, it does look like her primary care doctor, Dr. Rathbone, had referred her to me, and it looks like from my notes that I'd referred her to Dr. Barrett Johnston for treatment then. She had a history of chronic neck and back issues, and at that point, we sent her to Dr. Johnston for both and wanted to work it up with MRIs of both her neck and back that were current. We also sent her over to Dr. Linda LaBourgeois, a neurologist, for evaluation of her legs and back. And ultimately, it culminated with her, the recommendation for a C4 to 6 ACDF on 2/16 of 2015, as after the MRIs and clinically she had cervical stenosis with radiculopathy from C4 to C6. And specifically in regards to the neck, we recommended a C4 to 6 ACDF at that point, as she had both cord and root compression that was giving her trouble. And so that's ultimately what we did do for her as far as the neck goes that first time around.
And as far as radiculopathy is concerned, can you explain that?
Sure. It's when the nerves are pinched in the neck or in the low back, but in this case in the neck, and they create subjective complaints of typically pain and or numbness, tingling, or weakness, and then they correlate clinically with the areas where they're pinched, where we know the nerves run.
Okay. So doctor, you'd operated on her neck before this incident at Walmart. Did you feel that you fixed it? I mean, how would you know the result of that?
Sure. So we did the surgery, as I said, in the spring of 2015, and ultimately we followed her for a number of visits after that. She, as we noted before, had a pretty bad back that obviously I'd already said, needed ultimately the surgery that's not related to this accident, I don't believe, as far as the back goes. But she also had a rotator cuff issue that had gotten fixed per se with Craig Green. But the last visit that I have before I think this accident in question was on 3/11/2016, which I guess is about 7 months before that. And at that point, she was still doing quite well as far as the neck goes, didn't really have any complaints, or at least not reported to me, as far as her neck or arms go at that time, and continued to have a lot of problems with the back and legs and some urinary issues. And so at that point, there was nothing really to do. There was no further treatment per se at that point for her neck. And so I just sent her back off to Dr. Johnston, as well as the urologist, for review for other things, and then discuss other things potentially for her low back.
Did you have any type of imaging study or anything to confirm that her neck had fused?
Yeah, her x-rays post-operatively had looked quite well and didn't demonstrate any significant motion on flexion or extension views, which are typically what folks will do unless there's a need for more advanced studies, demonstrating less than a millimeter of motion at each level from C4 to C6.
So at that time, as of March 11th of 2016, did you feel that the surgery had been a success?
I thought there had been. I mean, she wasn't complaining of neck or arm pain to me, and overall, I mean, obviously we stopped the progression of her cord symptoms, which were also certainly present.
Can you show the jury where, using this model, that you had fused her originally prior to Walmart incident?
Sure. So this is kind of like looking at it from the front, and this is the skull, and then you just count down: number 1, 2, 3, 4, 5, and 6. So in between number 4 to number 6, which this is number 4, and then 5 and 6. So we took out these 2 discs right here, this one as well as this one, and had inserted 2 bone grafts or structural allografts in between where these discs had been previously located, that had both disc as well as bone spurs pressing on the nerve roots as well as the spinal cord. And we placed a small plate on the front of the spine from C4 to C6.
Could you explain a bone graft to the jury, please?
Sure. So a bone graft is, well, understand that in the old days, meaning typically before 1980, for something like this, just an anterior discectomy would be done, and just removing just the disc, taking the pressure off the nerves or spinal cord, and then just letting the space kind of collapse on its own. But this ended up ultimately over time, certainly the gold standard has come to where an anterior cervical discectomy and then a fusion has been performed, and that's where we fill that space with a graft. Now the graft can be traditionally from a piece of the pelvis, or harvesting a piece of this bone, cutting out a piece, and then placing this in between the bones, or taking that from a cadaver bone, or using what we call like a cage, which can be either plastic or metal, or the 2 most common materials that take the space, that are filled with bone graft.
Doctor, those levels either above or below the fusion sites, which were here, I believe you said C4 to C6, are they more vulnerable after a surgery like this?
They are more vulnerable than per se if they had not had one. But the chances of that traditionally breaking down after, in this case, a C4 to 6 ACDF, which is what she'd had done before, the risk for that is about 2.5% to 3% per year. That ultimately typically culminates out at about 30 to 37%, anywhere from the 10 to 17 year mark, which 17-year data is the best that we have in follow-up with multiple different studies at this point. But none show development of symptomatic adjacent segment, whether you want to call it disease or degeneration or pathology, that requires treatment. It doesn't mean surgery at greater than 33% at long-term follow-up, which is, it's more likely than not likely to need surgery on its own.
Okay. And doctor, I understand you've seen the video of this incident previously, but we have it queued up here. If you don't mind, we'll play it. And could you comment to the jury what you see happening as these boxes are falling on her, how her neck is being affected?
One moment.
If maybe we could play it one more time. So as far as that event goes, what does it tell you about what her neck is going through?
It looks like she's standing to the left-hand side, at least on the video that I'm reviewing, which is filmed from the back side of her. And it looks like these boxes are either falling off and landing directly on the right-hand side of her neck. It looks like her neck may slightly go forward at the time of this injury or this event. And but there's definitely some boxes that fall, and she immediately reaches up and grabs her neck.
So, doctor, you've done a neck surgery at this time prior to this incident with Walmart. She reflected, at least as of the last visit with you, that she was doing fine, and then we have this event. What changed in her spine that caused you to need to do that second revision surgery?
Well, she came back to me as far as from a neck standpoint goes, and after this incident was having recurrent symptoms in the neck and upper extremities, and that was the event, best from my records review, and what she's told me, that while we ended up getting and seeking additional diagnostic studies and then subsequently treatment for that.
Did those additional diagnostic studies reveal any change where you'd done this prior surgery?
They did. I'd commented, I think, after her myelogram that was done, we did have that done, and I commented on my March 17th of 2017 note, and it looked like there was a solid fusion that had occurred at the C4-5 level, the top level, but at the C5-6 level, there does appear to be a clear line that can be visualized. And just so that we're all on the same page, I know you have to zoom in here, but this is the CT myelogram from the Spine Hospital of Louisiana on Mickey Singleton. And this is from, let's see here. Looks like I may have dated it wrong, but I don't know that I have the date included here, unfortunately. But anyway, I'm showing you. We'll have to look at that. What's that date? Excuse me.
Testified it might have been January of 2017.
Yes. Okay, here we go. There it is. 1/5 of 2017. And what you can see here is, as we count the bones here, this is number 2, 3, 4, 5, and 6. So this shows the old surgery between number 4 to number 6. And what you can clearly see here is between number 4 and number 5, these two bones are completely bridged together. Okay, you don't see any space or gapping. That's a solid fusion. Okay, this shows you what a disc space is that has not had surgery. You see this black gap between the bones. And then compare that to number 5, 6, which clearly demonstrates a black line, okay, all the way through, whether it's from front to back, okay. This is in the front of the neck, this is in the back, and here's the spinal cord behind. Or whether or not you look at it like this, okay, which is a frontal view, what we call a coronal view, in which case this is the right-hand side, this is the left-hand side. Now compare a solid fusion where the two bones once again have totally grown together, okay, compared with the C5-6 level, which demonstrates either a fracture or a crack through this graft all the way, you can see it here, versus a pseudoarthrosis or non-union at that area, okay, which is what I had showed there. Now, there was some bone spurs that we did note down below at number 6, 7 below, okay. Now, we didn't really include those in the first surgery because the cord was just compressed at number 4, 5, and 5, 6. And I thought that that's all we really, quote, had to do to get her better. And I think that it was pretty successful. But now that is also noted at the level below. But the main feature is that crack at number 5, 6.
Doctor, would you associate that crack more probably than not with the boxes falling on her head at Walmart?
I would.
Okay. After this time, we've done this imaging. You testified you performed a second revision surgery. Was that different from the first neck fusion you'd done before Walmart?
Well, it's a little bit different in the sense that the main thing is addressing this fracture or crack. It's difficult to do that really just from the front alone. You're really not going to be able to mechanically stabilize this significantly more. And whether it's a fracture versus a pseudoarthrosis at that level, that is now giving her a lot of trouble. Typically, we would address that posteriorly if we've already addressed it from the front. So that was part of the the recommendation. We also discussed that you can get a more solid fusion by also regrafting it in the front versus exploring that area, as well as we couldn't be completely certain that she wasn't having some symptoms from some of the bone spurs and the other problems that she had below at the 6-7 level. And so she asked me which would heal at a higher rate, and we discussed a posterior operation alone to also include that 6-7 level, in addition to the one that had the crack or the non-union at the C5-6 level. And clearly, a revision anterior and posterior fixation is going to heal at a much higher rate than a revision anterior alone operation or just a revision posterior alone operation, particularly if we're going to include the 6-7 level.
So you'd mentioned the crack in that graft, and then you used the term pseudoarthrosis. Can you describe that?
Sure. So it just means false joint. That's what the two root words mean. Pseudo, meaning false, and arthrosis, or joint. And so, but it refers to the two bones either not healing or, in this case, becoming cracked or fractured. To be honest with you, it's almost impossible to tell, and they would almost look identical with a CAT scan imaging at the 3-month mark, which is when this CAT scan image was typically was done after this incident.
So the bone graft crack or the pseudoarthrosis, whatever, and I know you've testified the crack. Was that something that was there when she saw you last before this Walmart event in March of 2016? Was that something she had, that crack?
Well, it's either one of only two possibilities. It did not appear that it appeared that she had a solid fusion previously from her imaging post-operatively, in my opinion, after her initial surgery. But if she did have it, let's hypothetically assume that even if it were there, it wasn't significantly moving on flexion and extension views. Therefore, it would be a stable pseudoarthrosis versus an asymptomatic stable pseudoarthrosis for which no treatment is required.
Okay. You mentioned the difference in the surgery from the first one to the post-Walmart. Do they take longer, or does the hospital stay different? Is there any difference in recovery?
It is. It's a longer recovery. I mean, when you go through the back of the neck, you have to basically elevate the muscles off the back of the neck, and it hurts more. So, and when we're going back through the front of the neck, we do have to make sure that it's okay from the ear, nose, and throat standpoint, that the nerves going to the vocal box and whatnot are okay. And they were, so we could go on the opposite side with a little bit less scar tissue than if we had to go back on the same side as what we had gone through the first time. But the recovery is more difficult.
So as you'd done after the first neck fusion, where you did some imaging studies to look what happened, did you do the same type of additional imaging after this second post-Walmart surgery?
Well, I mean, the same thing is that we followed her and continue to follow her, and got post-operative images that did not show any complication from these two levels, C5-6 and C6-7, on those films. So that's kind of where we were.
And to the extent that you continued to treat her afterwards, and you continued to talk with her, and again you had that post-surgery imaging, did it appear that it worked?
It looked like she had a solid fusion from C4 to C7, best that I could see on any of her plain film imaging.
Okay.
And I believe I noted the ones from January of 2018, and at that point it looked like solid fusion. Therefore, I didn't order any additional X-rays after that point.
Okay. Now, you've explained the neck fusion caused by this Walmart incident to the jury. Can you help the jury understand what's next for Ms. Singleton's neck? What else can she look into if she's got future complaints of pain?
Yeah, I mean, as you'll see from my different notes, I mean, I've followed her, and obviously, as we'd already noted, we did, I thought that the low back wasn't really related, in my opinion, to this accident from L4 to S1, but we've continued to follow her for that. She's continued to have, at least from my notes for review, she's had more issues that have persisted with her low back and legs and whatnot, but she still follows up with Dr. Barrett Johnston as far as her overall pain goes. But she's not had as much issues per se with the neck as she's had with her low back. But
So you've mentioned she's not had as much issues. I assume that to mean that she's had some residual neck complaints.
yeah, I don't have all of her pain. Excuse me, I don't have all of her pain management notes, but it's been brought to my attention that her pain management doctor has wanted to continue or has had to treat her some for the neck with some continued or residual complaints, and so. They've asked me what I think the future medical treatments may be for her, and I don't think that she's going to need an additional cervical fusion with the same literature that would be applied beforehand being applied here. I do think that it's certainly within the realm of the pain management doctors for them to continue to treat if they're having a lot of issues with the neck. I think one thing that was posed to me was what may be necessary. Certainly injections may be necessary at either the level above or below a fusion, as I've discussed. But if there's significant issues, one of the pain doctors had asked me whether or not a spinal cord stimulator was a possibility. I went back and reviewed my procedure and my notes. Initially, in general, when we do a posterior cervical operation from the back of the neck, the most common thing to do is a full laminectomy in addition to the fusion, which will certainly have what we call post-laminectomy scar tissue, which would be expected, not really a complication. So I think at one point it was posed to me, and I said that couldn't be done, but when you go back and look at the actual procedure that we did, it was foraminotomies at that C5-6 level as well as C6, C7. It wasn't a full laminectomy. Therefore, that post-laminectomy scar tissue will not occur in the midline, which is where a spinal cord stimulator lead would be placed, whether it's a trial or potentially a permanent implant. And therefore, it doesn't preclude from a technical standpoint that is a possibility if her pain management doctor felt that may be indicated. That's a procedure that I don't do, which is a cervical stimulators. That's typically a pain management procedure. Therefore, as far as whether or not that will or won't be needed, I would just testify as to its technical feasibility, and I think that it is technically feasible to do.
Given that cervical implant that you discussed would be to address neck pain, which, as you've testified to, was caused and related to this event, would you say that if she had that spinal cord stimulator implanted, that would be related more probably than not to the Walmart incident as well?
Yeah, as I said, I would defer to the pain management doctor. If it's been continuous and they've continued to treat and show that they've had some continued issues, then, like I said, I would defer to them because, on my notes, she'd done pretty well for a number of the notes, and the vast majority of these things were focused on her low back and her legs, which, as I've testified, doesn't relate to this accident, I don't think. And so I really think that, if that's the case, then hypothetically it certainly may, but I would defer to the pain management doctor regarding that.
Okay, and Doctor, Walmart had hired some doctors, what I would call kind of medical critics to review some of the work that's been done so far on Miss Singleton, and they did, and the doctors seemed to be saying that the surgery wasn't caused by trauma, but rather degeneration, just natural course of aging. Specifically, and I believe you know Dr. Curtis Partington, he was a local neuroradiologist. He testified that he didn't see any crack in the graft and that this bone plug was intact. Having had the benefit of looking inside Miss Singleton and showing us these images, are you moved by that testimony at all?
Well, even before looking inside of her on the second surgery, I mean, maybe we were looking at different images than the ones I just showed you from January of 2017, but there's undoubtedly a radiolucent line that extends obliquely through on both coronal and sagittal images. So, you know, maybe if Dr. Partington would see this film, he might say something different if he reviewed my testimony today. Or maybe we were looking at different images, but I clearly could see it. Additionally, when on gold, I mean, really the gold standard is an exploration of the fusion as to whether or not there is or is not motion present, whether that's from a graft fracture versus from a pseudoarthrosis. And in this case, I mean, she did have motion at the C5, C6 level, and so therefore we did do a revision fusion there. Okay. If she had no motion at all, then we would have just simply fused just the C6, C7 level, but she did, which is why we then respanned and rebridged both anteriorly and posteriorly, not only the C6, 7 level, but also the C5, C6 level. And if you notice my construct after the second surgery, the implants, we took the plate off. We didn't apply additional hardware at the C4, 5 level. It was solid on intraoperative inspection. There was no motion. There was no need for additional fixation at that level. Therefore, it wasn't applied.
And Doctor, Ms. Singleton had reported falling at a fair a couple weeks before this Walmart incident. Do you recall hearing about that? I think it was to her primary care physician.
I don't recall.
You don't? Okay. Well, she didn't come and see you after that, correct?
Yeah, I think it's been brought to my attention that may have been brought to my attention in the first deposition. Without me reviewing my whole first deposition, it's difficult for me to recall at this moment.
Okay.
But I don't believe she saw me directly after that fall.
Certainly Dr. Rathbone didn't refer her to you to see you for that after that fall.
I don't think I have a note noting that.
Okay. And is there any indication then that fall at this fair did any of the structural graft fracture to her neck?
I mean, I don't know if she hit her head or if there was a direct blow. I mean, if it was something like what we just saw on this video, then it's certainly a possibility that could have done it. But, you know, if she didn't have a direct strike to her head or neck area, then I wouldn't think that would cause a fracture or a crack or whatnot, what we saw.
So if she had testified that she stepped in a hole, fell to her knee, and caught herself with her hand, would that change any of your opinions about how this happened, how this second surgery came to pass?
No, assuming that she didn't have a direct blow.
Okay. And then finally, Doctor, before I turn you over to Mr. Hardy, over the course of your treatment of Miss Mickey Singleton, have you ever seen any signs or red flags that would give you cause for concern over her honesty or credibility?
I have not.
Okay. Thank you, Doctor. I'll tender to you.
Good evening, Doctor. My name's Sid Hardy.
Good.
Pleasure. Doctor, I want to ask you a few questions now about pain and the testing of pain. I understand pain is subjective. In other words, medical science does not have a pain meter that will tell you this person's in severe pain or this person's not. Is that correct?
I believe that's right. It's subjective.
Okay. And sometimes a patient can have pathology in, say, the spine or perhaps other parts of the body that clearly shows up on diagnostic studies, but the patient can either be symptomatic or asymptomatic. It can either be pain causing or non-pain causing. That's correct?
That's fair.
Frequently, doctors have patients fill out a pain scale or to tell what their pain level is on a 1 to 10 basis. So, have you seen that done?
Sure.
And 1 is minimal pain, and 10 out of 10 is what, the worst pain imaginable?
That's fair.
Okay, so that would be like agony, basically.
Yeah, everybody's subjectively different.
Right. One person's 10 might be another person's 3.
Sure.
Okay. As a treating physician, you have to depend upon the patient being truthful about the location and the intensity of their pain in order to treat them properly. And you treat them based on that reliance.
Yes, that's one thing we definitely do rely on.
Okay. Now, if they're not in pain, you're not going to, it would certainly change your course of treatment as opposed to if they were in pain.
Depends on what they have. You know, maybe they have a spinal cord tumor. They may not have any pain, but they could have something that could be dangerous to them.
Right, or they could have something squeezing the spinal cord and they have a loss of sensation.
Right, they may have a significant weakness or a neurological problem, but they may not have much pain.
Sure. I want to talk to you a little bit about our pre-Walmart accident history, and you've already referenced it a little bit. We know she had long-term chronic low back pain, probably going back at least since 1995 or so.
I believe that to be true.
And chronic means pain that's ongoing, on a daily or a weekly or monthly, or in Miss Singleton's case, perhaps yearly basis, year after year, correct?
Correct.
She also had chronic neck pain since, I believe, about 2012, arising out of a car wreck. Is that correct?
I don't think I noted exactly what caused her pain in 2012 or
Okay,
whatnot
but she did
before.
have a chronic neck pain going back to around 2012.
Yes.
Yeah.
Well, like I said, I don't know about 2012. I just know that she had chronic neck pain. And I'd noted that in my first note from January of 2015.
And you also know, and you referenced this, that she had also had some chronic pain issues with, I believe, her knees and her shoulder.
Objection.
Prior to the Walmart accident.
Yeah, I don't know.
I know you didn't treat her for that.
Yeah. Assuming that's what my notes say, then sure.
Yeah. She also had chronic headaches before the Walmart accident.
I believe she had some headaches.
In terms of surgeries, prior to this incident, she had undergone 4 separate low back surgeries. Is that correct?
Objection.
I believe she had 3. I noted that she'd had 3 previous decompressions.
And she had one again in 3/30 of 15, didn't she?
Yeah, I didn't note that. I may have, if I look back on it, note that. I'm looking at my first note.
Yeah, and for the visit of Doctor, one problem when you bring a bunch of stuff to a deposition is being able to locate it.
Sure.
On the visit of 4/1 of 15,
Okay,
do you have that note?
I do.
Okay. Would you read up toward the top? I think as of the time of this visit, it said she had 3 prior decompressions.
Correct.
And then on 3/20/15, she underwent another spine surgery.
That's
lumbar.
That's no. That's referring to the neck, I believe.
Oh, okay. Well,
The
let me see
C4
if
to
I can.
6 ACDF.
Let's see. Did she have a lumbar surgery in 2015?
I don't believe so.
Let's see. Did it come to your attention that she had also had shoulder and knee surgeries
Yes,
in 2015?
I do believe I do believe that to be accurate.
Doctor, you didn't prescribe any medication to Miss Singleton, did you?
I can't recall if I ever gave her anything but I mean, primarily she had pain management doctor.
She had pain management doctor before the Walmart accident.
Yes, I mean, I think she's, as we noted, she's had a lot of problems with this and with her neck and back, more with the back, as noted by the multiple surgeries. I believe Dr. Bruce already done on those.
You're aware that she has, for a long term, has been taking opioids on a regular basis?
I did note that.
And I'm going to ask you to assume that during the months before the Walmart accident, up until a month, and at the time of the Walmart accident, she was regularly receiving 100 tablets of 30 milligram oxycodone per month, which would be 4 pills, 4 opioid pills per day. Were you aware of that?
I don't know that I noted 30. I noted that she had roxicodone 15 milligrams a couple of times per day that I noted on that first note.
And instead of showing you the prescription records, I'm going to ask you to assume that that is what she had been prescribed every month prior to the Walmart accident.
Okay.
And assuming that's correct, would that be considered high dosage opioid therapy? 120 opioid pills a month?
Yeah, I
4
mean,
day?
as noted before, just to be consistent, I mean, I don't do chronic pain management, so when it gets into these kind of things, I don't prescribe that type of medicine at those dosages. I send them to the pain doctor.
Okay.
So yeah, it's high because I don't prescribe it.
And I'm going to ask you a couple more questions about long-term opioid use, and you may or may not know the answer, and if you don't, that's fine. Are you aware of the risk of long-term extensive opioid use, risk to the patient?
There are many risks and that's why I send them to a chronic pain management doctor to prescribe those.
I'm sorry. I guess, and we've all heard about this opioid crisis and all. Sure. One risk would be dependence.
Yes.
Dependence would be when someone has a physical need or dependence for opioids. Is that your understanding of what dependence is?
Depending on how you define it.
Okay. And this question is not necessarily directed toward Ms. Singleton, but one problem as a physician, if you're treating a person dependent on opioids, and that person is dependent and needs opioids, that person might have an incentive to exaggerate their level and intensity of pain. Does that sound right? Would you agree with that? And I'm not talking about Ms. Singleton,
sure,
but just in general.
Yeah, it's possible they could, but I've seen a lot of reasons why people may or may not want to exaggerate their pain.
Oh, sure, I know that's true, but it's also true that, for example, with somebody with a condition that either could be pain-producing or non-pain producing, and they need their opioids, they would certainly, and that the only way they could get them legally was through a prescription, they would certainly have an incentive to exaggerate their pain.
I'm not
Would you agree with that?
Is that a question?
Yes, sir. Yes, sir. And I asked, did you agree with that?
Well, no, I wouldn't agree with that because I wouldn't say they would certainly have an incentive to exaggerate their pain. That assumes that they definitely would exaggerate their pain.
No, sir, I didn't say they would. I said, would they have an incentive to if they wanted those opioids?
Or they may just have pain for their treatment. I mean, they could. It's possible, as I said before, but I couldn't say that it's probable or likely that they would.
The Walmart incident, you first saw her, what, a month and a half after the incident?
Yes, about a month and a half.
And we've seen the video where the boxes fell on her. She told you the boxes weighed 30 pounds?
I don't believe I noted how much they weighed.
If you would look at your note dated 3/17/17, I'll try to find this.
Sure. I see that note.
Well, you got to it before I did, Doctor. Let me see. Counsel, let me give it to you as well. Look at the last paragraph on the second page, Doctor. Oh, okay. Yeah, okay. Okay, and that's the first page. We're looking for the second page. And that last paragraph that begins with, "We also looked at some pictures." Do you see that?
I do.
It says that we looked at some pictures where unfortunately the boxes that landed on her head and injured her neck at Walmart were approximately 30 inches in width, the base square, and then about 36 inches in height and weighed about 30 pounds each. Do you see that?
I see that.
30 pounds, would you agree that 30 pounds is a pretty significant weight to land on somebody's head or neck?
That's a pretty significant weight.
Yeah. You would expect that a 30-pound weight, and I think she told Dr. Rathbone they were metal filing cabinets, something that fell and landed on somebody's head, they would have immediate and significant pain. Would you agree with that?
Certainly they could.
Well,
I mean, she did reach up immediately, and it's in the video that we just saw, and grab her neck, at least on the video I saw.
right. And so you would agree with me that if somebody drops a 30-pound weight on your head, you're probably going to feel some immediate and significant pain.
Well, it depends on the person.
Okay, so some of your patients, they could get hit by a 30-pound weight dropped on their head and they might not even know it?
Well, I didn't say they might not know it, but I mean, pain is subjective. So it's what somebody says it is. But we treat football players that have heavy weights dropped on them or have heavy loads placed on them all the time, and they don't complain. Or Marine Corps, or Army, Navy SEALs, those types of folks.
Well, if they're,
And
I'm sorry, go
we
ahead.
have other people that they may not even have 30 pounds dropped on their head that may significantly cause them pain.
Well, if they were still treating with you and they'd been hit with the equivalent of 30 pounds dropped on them, but you weren't treating them for that.
What's the question?
For 30 pounds of force hitting them on the head.
What's the question?
Well, you said you've treated football players who take all kinds of blows and heavy blows,
Right.
but you said they don't complain of pain.
Well, not as
from
often
that.
as, say, a lay person that's not in that type of shape or condition, but they could.
A 30-pound box dropped on somebody's head would likely cause a concussion, wouldn't it?
I'm not a neurologist.
Okay, so you think it might cause a bruise?
Well, a bruise underneath the hair, I mean, it could cause a bruise.
Sure. A 30-pound weight smacking you on the head would probably cause a bruise, wouldn't it?
Well, could cause a bruise, doesn't
Okay.
always cause a bruise.
Okay, all right. 30-pound weight dropped on somebody's head would, I imagine it'd have a knot on your head, wouldn't it?
Possibly.
Okay, so you're telling us that 30-pound weight hits you on the head, it wouldn't always cause a knot.
Always? No. I mean,
Okay.
it very well may not always cause a knot.
It could cause a fracture, couldn't it?
It could.
You would expect somebody who had just been struck by a falling 30-pound object on the top of the head or on the side of the head, they would probably need immediate medical treatment, wouldn't you think?
Possibly. I wouldn't say probably.
Okay. So they might So if I understand it, a 30-pound weight dropped on somebody's head, it may or may not hurt them, and it may or may not cause swelling. Is that what you're saying?
That's correct.
Okay. May or may not cause a concussion.
That's correct.
Okay. When would you expect the pain to start if you got hit with a 30-pound object? Would you expect it immediately, or would you expect it to last a few days go by before you feel it?
Well, it depends on the patient. Some people may be tough and just decide to tough it out until they realize something may not be right. And then some people go to the ER for everything.
I know these fusions, and a fusion is what it says. It literally, this plug, it fuses everything together, right? It's a solid, a solid bone, basically, right?
Yeah, that's what we were showing on those pictures earlier, where the two bones were completely solid and the one was not.
And it's secured by a plate, a steel plate with 6 screws, correct?
You're talking about in this case, or
In this case particularly.
In this case, it was secured. That original fusion was secured with a titanium plate and titanium screws.
Okay. And I think you said in your deposition that these fusions are a fusion that works and that takes, they can, you can have a football player go back and play football after they've had a fusion.
An anterior cervical fusion at 1 or 2 levels is generally accepted.
And it would take significant trauma to crack that.
Well, maybe not. I mean, if anybody that saw the Saints game last night, Eli Apple potentially tore a significant structure in his knee, but it was a non-contact injury. But he may be out for the year.
Oh, so you mean minimal trauma could cause a crack in a fusion?
Well, I'm giving you an example where these rough and tough football players, even in this case, didn't always have a huge mechanism or blow or direct blow to the head. But in this case, she did have a direct blow to the head. Certainly the type of mechanism which would support, like I said, in that last paragraph that you were referencing from March 17th of 2017 that we were just looking at, that said this is certainly consistent with a mechanism that would be significant enough to cause a disruption of the interbody graft, in my opinion.
She saw, let me see if I can find the report from Dr. Rathbone. Let's see. Mm. 11/1 of 16. Let me see if I can find it. Counsel. Doctor, here's a copy for you. You probably don't have that record.
This is 11/17 of 14. Are you meaning to hand me 2014 notes?
No, I mentioned no. No, I did not. Let me see. Let me see what I just gave the doctor. That's 1/7/15. Rather than fool with that, I'll just move on since I obviously can't find it.
Okay.
I'm going to ask you to assume that this is true. Assume that his examination, she said that she mentioned the accident and said their neck pain had been going on for about a week. She saw Dr. Rathbone 2 weeks after the accident and said her pain had been going on for about a week. He also found that her neck had a full range of motion. Would you find that unusual with someone that had a 30-pound weight dropped on their head and a broken bone in their neck?
At 2 weeks?
Yeah.
It would be a little bit unusual, but certainly not within the realm of what we define.
He also examined her neck and said her neck was supple.
Objection.
And I looked up supple, and it means, I believe, easily moving, extending back and forth, up and down. Is that what that means in medical terms?
Not really. Typically when we refer to a neck exam and the neck being supple, we're referring to the tracheoesophageal structures in the anterior thyroid, and that this is supple. Okay, so that demonstrates supple. That's typically what that word refers to, unless Dr. Rathbone has testified that that is specifically not what he means. But it would not mean that she has a full range of motion in all planes.
Well, I'm asking you to assume that she did have a full range of motion, and I think you've already answered that.
I'm just going with your hypothetical. You asked me what supple meant.
Yes, we were talking about supple, but in terms of range of motion, it is exactly what you showed, right?
It could be. I mean, unless it's defined with specific endpoints, then we don't know exactly what the range of motion was. He is a primary care doctor, which is certainly different from a spine doctor.
When she came to see you on 3/17/17, if you would go back to that, let me see if I still have that. Tell me when you're there, doctor.
I've been here.
Oh, okay. Let's wait for it to come up on the screen. It says, did she tell you on this visit that she wanted to get her low back fixed?
Do you want to refer to which part of the
Yeah, I'm looking
note
for it.
you have there?
Okay. If you will note this paragraph that says she is still having some pain in her neck, it's the second paragraph.
Okay.
The pain in her neck, she had some pain, but it paled in comparison to the problems in her back, which is still the same as it was.
Okay.
So, and I think you've already told us that her neck pain was much more severe than the neck pain.
The neck pain was more severe than the neck
No, the back pain, the low back pain.
Okay. Yeah, I mean, she's had more low back pain since the day I first saw her in January of 2015. The back has always been more troublesome for her. But when she came in on 12/5/2016, as you note, I mean, the pain in her neck, it was a 7 out of 10. It was not insignificant. And that doesn't mean that a lot of times people will say it's a 7 out of 10, and they still may also use the verb, it pales in comparison to the low back pain, which was a 10 out of 10, which normally we would think, oh, it's 3 out of a 10 difference. But to somebody else, that gives her a lot of trouble.
Do you have your note from 12/5/16, doctor?
I do.
Would you go to that, please, sir? Let me see if by if I can find it. Here it is. 12/5/16. let me direct you to the interval history. Now this is 12/5 of 16. This is her first visit with you, I believe, doctor, after the Walmart incident. She said, Miss Mickey returns. We saw her on 3/11/16. She has finally gotten to the point where she just cannot take it anymore and she wants to get her back fixed. Do you see that?
Correct.
Now, my question is this. You had performed, or she had already undergone 3 surgeries prior to this, and she did not seem to have, she still complained of pain.
For the low
Right?
back.
Yeah, for the low back. And I'm wondering, as a surgeon, do you ever reach the point, and once again, not necessarily with Miss Singleton, where it looks like surgery just doesn't work for a patient? You know, she's had 3 surgeries, or this one in particular, she's had 3 surgeries. Now she's come back and said she wants to get her back fixed. She wants another surgery. Did it give you pause in any way, since she had already had 3 unsuccessful back surgeries that she didn't get relief from?
Well, it looks like she had the wrong surgeries done.
Okay.
She kept getting revision decompressions. And maybe back in 1997 and 2002 and in these older days, it's really not for me to look back without those MRIs, unless we all have them and we can look back at what was going on at that point. I think Dr. Broussard, I wouldn't say that he did wrong surgeries back then, but clearly this woman has more than simply a disc herniation. She now has multiple additional diagnoses which are more complex, for which she'd never undergone a fusion to appropriately treat her problems with her low back pain. So it's not quite, and it's just really not appropriate to phrase it like that, I would say.
Okay. Doctor, the crack in the fusion that you saw, and you fully explained it, although as a spine surgeon you frequently look at diagnostic film and interpret it, you're not a radiologist.
That's correct.
This CT myelogram was performed at the Neuromedical Center, I believe.
Correct. Yeah, that's what we went over.
Do you have the CT myelogram report, radiology report with you?
I may.
If you don't, that's okay.
Okay, it looks like I've got the lumbar here. Yeah, I've got the cervical.
Did that radiologist at the Neuromedical Center report a fracture in the fusion plug?
No, his description was, and I did ask him about this, Dr. Williams, about this case. It notes ossification of the disc at C4, C5. It means solid fusion. Notice he didn't say ossification of the discs or disc space at C4 to C6. He said narrowing of the disc at C5, 6, and the coronal reconstructions do suggest some bridging bone fusion anteriorly at C5, C6. So I asked him about this because I knew this would come up. And his comments were, well, we don't like to comment unless it's specifically asked to comment directly on the fusion status. And I'm just telling you it's not just there, it's at other places too. Radiologists, a lot of times, naturally, I say, well, why not? I just wish they'd just call it specifically and say, because in this case, you can clearly see on the coronal and the sagittal images a significant lack of bony bridging or fracture.
And you said it was clear. Anybody could see it. Any radiologist could see it.
Well, yes, and so that's why I asked him about this case, and especially before I did revision surgery, and he agreed with me that there did appear that it was certainly at least not as solid or perhaps not fused at the C5, C6 level.
Okay.
And so, as you see in my note from 3/17/2017, that first kind of paragraph kind of alludes to that, in the sense that there's a solid appearance fusion at C4, C5. However, at C5, 6, particularly on the sagittal images, which, as he notes in that paragraph, it even says this is poorly demonstrated on the sagittal views. The bony bridging, that is. It's poorly demonstrated. Okay? Well, that's a pseudoarthrosis, okay? Or that's not a solid union. It's not the same word that he just said 2 to 3 sentences before, that there is solid opacification. But before we went and did revision surgery, that's why we wanted to make sure, okay, there is no significant bone bridging versus a graft fracture, which is what I've clearly demonstrated here, okay, on these images that we've been able to review today. And the vertebrae do not show evidence of a fracture. That was his opinion. However, the radiologist reads that it is a pseudoarthrosis versus, so the point is that the language utilized for the C4-5 level as well as is not the same as the language at the C5-6 level. And that was in his original film report that he issued. But I wanted to make sure that before I go and try to indicate this woman, because she's still having significant pain, and I do think there is something wrong here, and indeed that was the case, because when we got into the anterior neck, there is gross motion of that disc space level. We've already gone through this, and I don't want to belabor the point with the jury and the judge for everything we just said beforehand.
Doctor, on your 3/17/17 visit, you have that in front of you, don't you?
It's still here.
Okay. And you don't have to put this up. You will see in the first paragraph, you said the plate and screws are intact with no complication and no sign of loosening of the plate or screws. Alignment is preserved. Now, obviously, that's a good finding from that study. Would you agree?
That is a good finding, and which makes it more likely, in my opinion, that it's a fracture rather than a pseudoarthrosis. Because a pseudoarthrosis, if one didn't heal, typically you will see some type of haloing around the screws or lucency around the screws or something like that. But obviously, as I don't have to go into detail here, the toughness or the rigidity of metal is harder than a bone, whether or not it's your native bone or a bone graft, as what was the case was utilized. So it's going to fail more frequently at the bone site rather than the metal or the plate site.
If the plate and the screws are intact, that means it's holding everything in place. Fair statement?
Well, it means that just what I just described earlier. They're not dislodged from the bone. The screws aren't loose or prominent, okay? So
you have that plate screwed in. It prevents motion, doesn't it?
it does prevent motion.
Okay. Doctor, go to your 2/24/17 report and tell me when you get there.
Okay.
Oh, I may have given you multiple copies. Okay. Okay, Doctor, second paragraph. In regard, let me see, to her smoking status, we called Ms. Mickey. She said that she's been able to stop smoking, and this was confirmed since the last time we had seen her on 12/5/16. She has indeed quit smoking since her cervical surgery, and her patient intake form reflects that from 12/5/16 she has not continued to smoke at this time for greater than 3 months. Sometimes fusions just don't fuse. I mean, attempted fusions don't fuse. They call it a failed fusion without trauma. Was that a fair statement? Sometimes it happens.
Yes, they can either fuse or not fuse.
Yeah. And if it doesn't fuse, it's a failed fusion. Correct?
Depends on how you describe failed fusion. It could be a radiographic failure, but it may not be a clinical failure.
Yeah. Smoking is one of the risks, I believe, it elevates the risk of the fusion not becoming solid. Is that true?
Radiographically.
Yeah. I know she told you she had stopped smoking. And I know she told you that she's your patient. Did you do any independent tests to determine nicotine or smoking, anything like that?
I didn't, but I don't believe I did. At least, I mean, I don't have a cotinine test here ordered. That being said, I've known Miss Mickey for years, and I've smelled smoke on this woman. For years, I smelled smoke on this woman in the past, and I didn't smell smoke on this woman. So, and as we've noted, I mean, she seems totally reliable, and there's no reason for me to discredit her. So I didn't order a cotinine test.
Yeah, I understand. Same, if you could put 22417 up again, one more question. In regard to her level of disability, do you see that? That's the fourth paragraph.
Sure.
She still has significant daily back pain and leg pain that does still cause her to take narcotic medicines. It's not isolated to the leg alone. It is both back and leg pain to the point where she says it is 50% in both the back and 50% in the leg, requiring significant narcotic medications. You see that?
I do.
In your review at that time, her need for narcotics was based on her back and leg pain, according to this.
Yeah, I think the context of this note would provide a lot of clarity for you
Sure.
as well as the judge and jury.
Sure.
Notice the first sentence. I had a conversation with Dr. Roy Rush regarding Mrs. Singleton and her case. So Dr. Rush, he works for the insurance company, the medical insurance company, and this entire conversation was about her, as you will see in the last paragraph and extending onto the second page. This is all in regards to preparing for a lumbar fusion. So the whole conversation here is discussing her whole reasoning for her lumbar surgery. This is not an office visit stating what Mrs. Singleton was complaining about extensively or comprehensively. This is completely in regards to getting her lumbar surgery, her L4-S1 fusion, approved.
And so that's the reason for the statement that what her narcotic usage was related to.
We're talking about her low back, not her neck.
Okay.
For this whole note,
Right.
the context is very helpful, I would think.
And Doctor, lastly, you mentioned that you thought she was doing pretty well post her first cervical surgery in terms of pain, etc. Correct?
Yeah, we've already gone over the notes. Maybe we can do it again.
No, I don't want you to do it again. Are you aware that there were some sporadic complaints of neck pain, maybe 3 or 4 between after she had recovered from the first neck surgery but before the Walmart incident?
I mean, we followed her for a number of different office visits after the first neck surgery and extending up until 3/11/2016.
Okay.
If you have some notes for me to review from other providers between 3/11/2016 and October of 2016, maybe I could comment on those.
Have you ever heard the phrase masking when it comes to complaints of pain?
You'll have to define what that might mean a little
My
bit
understanding is masking is when a person has severe pain in a part of their body that's to such a degree that they don't realize they're having pain in another part of their body. Have you ever heard of that?
I've heard that.
Okay. Do you believe that that's true?
Possibly.
Okay. We know, for example, that Miss Singleton has constantly had severe low back pain, and we've already seen that. I don't want to belabor that. So that's certainly a possibility, wouldn't it?
A possibility for what?
That her neck pain was somehow masked because of the severity of her low back complaints or her knee complaints.
Yeah, as I've testified before, in regards to the knee and the shoulder, I would say, I may not have commented about that, but when you do cervical surgery on someone, you're going to ask them and note whether or not they have neck or arm pain after a cervical surgery, particularly in the first year after cervical surgery. And you're also going to ask them when they have ongoing diagnoses that require treatment, as we've noted here, for their low back and their legs, about their back and the leg pain. The 4 things that we will always ask somebody, particularly after cervical surgery or lumbar problems, in this case, not surgery at this point in time that you're referring to, is 4 things. What's your neck pain? What's your arm pain? What's your back pain? What's your leg pain? So I can tell you right now, without question, that at least on the dates when I was seeing it, and I was recording here, that she was complaining of her back and her legs, but she wasn't complaining of her neck and her arms leading up to the 3/11/2016 notes, predominantly. So I don't think that her back issues leading up to my last note on 3/11/2016, to be clear, were masking any potential cervical issues as might be suggested here, in my opinion.
Thank you, doctor. No further questions.
Doctor, I have a few follow-up questions. We just mentioned the 3 or 4 complaints of neck pain in between that first surgery and this Walmart incident. Again, because you ask each patient this at every visit, that wouldn't be uncommon, would it?
Object for leading.
Wouldn't be uncommon for what?
Doctor, have you heard or seen anything that Mr. Hardy has showed you that changes your opinion that Miss Singleton suffered an injury in this Walmart incident, more probably than not, to her neck, requiring surgery and future neck treatment?
No.
Okay. Doctor, Mr. Hardy brought up a lot about this 30-pound box. The parties have stipulated that the box was 12 pounds. It seems like we went a long way, focusing on a hypothet that doesn't apply. Would you agree?
Well, I would say that if it's 12 pounds, we all know momentum equals mass times velocity. So this mass obviously is not as you saw from that video, she was hit from a height. The potential energy up above, this height was not 0. So that 12 pounds is going to be obviously multiplied, not divided, not subtracted. So the force is going to be, or the momentum is going to be significantly higher.
Doctor, is there any evidence outside of this box fall on her head that you're aware of that could have caused this graft fracture and the subsequent second surgery?
No.
And doctor, you had previously on direct testified that the lower back pain and the lower back surgery are not in any way related to this fall, correct?
That's right.
Okay. So the fact that she had it concurrently or at the same time, that doesn't change your opinion on her neck, right?
No.
Okay. You were asked about the smoking. You saw a solid fusion after the first surgery, didn't you?
She
Object
had,
form leading. Go ahead.
Did you see a solid fusion after the first surgery?
yes, I've already testified that on standard flexion and extension radiographs, which is the standard for postoperative follow-up in patients that have had anterior cervical fusions, and you'll measure the distance that is in between the spinous processes at the exact same marks at multiple visits, that less than 1 millimeter of motion per level, or in this case, less than 2 millimeters of motion measured at the same intervals, is consistent with a solid fusion. And I thought that she had a solid fusion.
The last thing I want to show you, doctor, is this note of February 24th, 2017. And I'll ask the videographer to please place this first page on the Elmo. You were asked to testify up to the extent of the underlined portion. And you testified if both back and leg pain prior to the point where she says it's 50 in both back and at 50 in the leg, requiring significant narcotic medication. Rather, that's what Mr. Hardy said. What did he miss right there at the end?
For which she would like to be able to stop.
Okay. I have no further questions, doctor.
Okay.
This concludes this videotape deposition. We're going off the record. The time is 9:22.
Okay.